So thank you very much, Dr. Chandramohan and team, for inviting to this great conference, all big minds in colorectal cancer. I think everybody is talking of laparoscopy, but in India, we are dealing with almost 40 to 50% of the cancers which are T4, beyond T4, and that is why this topic was selected. And let me have a consensus on multivisceral resections. Are we justifying to do it, or are we doing too much? So locally advanced colon cancer, by definition, the colon cancer reaching beyond serosa, that is beyond T4, and involving the adjacent organ. And multivisceral resection is the answer because the adjacent organ is already involved. And it should be en bloc removal of the primary tumor along with the adjacent organ, en bloc. Then only it is called as MVR, that is multivisceral resection. And is it curative or palliative? Some situations happen in palliative when the patient is bleeding or sometime obstructed, and when we went in, we get in a situation where multi-organ to be resected. And definitely, if you do a proper pre-op assessment with the CT scan, MRI, PET-CT, it is definitely curative because you can achieve R0 resection. So that is the key in doing a curative resection in multivisceral resection. Now, visceral metastasis versus adjacent visceral involvement. Metastasis means it is already stage 4, but what we talk is adjacent visceral involvement, which is still localized but locally advanced. And the exclusion from our MVR series is inadvertent splenic injury or incidental GB removal because of some cholelithiasis or liver metastatectomy. And sometimes in colon, you find synchronous resection and you do a double resection. That is not MVR. It has to be primary tumor which has involved adjacent organ, and then it is called as MVR. And the aim of this surgery is to achieve R0 resection. R1 resection is only if palliative, and try to do R0 resection. Pre-operative proper planning is the most important. And 15 is the minimum number that they say, because it needs multi-talented oncosurgeon to do both uro-oncology, GI oncology, and whatever resections you do, diaphragmatic resections, all this can only be done by an oncosurgeon. If it is to be left to a site-specific team, I think it will need minimum 2 or 3 teams to complete the procedure. So it is very important that a qualified oncosurgeon takes the lead and does this assessment by doing the PET scan. Triple phase CT scan I always do in all the patients because that is the best investigations where you can plan if you want to do a pancreaticoduodenectomy, if you want a distal pancreatectomy, you want to a splenectomy, whatever you want, you can do very well with a triple phase assessment, colonoscopy, and endo-US if required to know any vascular structures to be resected. So all this needs to be done pre-op. And follow-up usually, we followed up our cases 3 years, and chest X-ray, ultrasound, colonoscopy is the standard. But sometimes if anything is there, then we do CCT and PET-CT and serum CA level. So, and intraoperative decision making is the most important, because here, if you want to send frozen, how many margins you will send? it is not possible. So intraoperative decision making by the surgeon to know that what is resecting and what will the margin, mostly they are organs. So I think they will be having very good margins. So you need not have a frozen section for margins except in a right hemicolectomy, which is sitting on a pancreatic tumor. If you're going for a pancreatic duodenectomy, you don't need. But sometimes we shave off from the surface, where definitely you will need a frozen section to prove. Otherwise, if it comes positive, you convert it to a pancreatic duodenectomy instead of a shaving procedure. So definitely on-table decisions are the main, during laparotomy, the main decision making. And common organs involved in colon, because tomorrow will be rectum. I'm only dealing with the colon. If it is viscera, spleen, liver, uterus, gerota of the kidney, most of the times we do partial nephrectomy. And it can be abdominal wall, ovary, omentum, and definitely for right colon, duodenum, pancreas, stomach, and very common with the sigmoid colon is the bladder, because it sits on the dome of the bladder. In one patient, I resected sigmoid colon, right hemicolectomy, because it was adherent to the terminal ileum. And then during that procedure, we found that the ureter is involved. We have to create a ileal ureter to do the ureteric anastomosis. So all these multi-resection are decided on table. Imaging are definitely helpful, but surgical resection during the surgery gives the best decision making. Sites of failure, mostly because they are locally advanced, over 3 years they mostly present with later on follow-up on metastasis. Local recurrence is less, but if you have done a good job, but sometimes they present with local recurrence and is around 10%. And nodal failure definitely depends on the aggressiveness of the primary tumor. Nodal failure might occur. And sometimes they all happen and giving a blink outcome to your such massive resections in a later on time. Recently I had this patient. I had done a right hemicolectomy before, 2 years back. The cecum was completely adherent to the psoas, and primarily we had done a partial excision. This came out to be poorly differentiated adenocarcinoma. The patient came back with a large mass in the psoas with infiltration to the kidney, and you can see it is going up to the ribs, 11th and 12th rib, and the diaphragm. So we resected as Dr. Subramanian Rao sir told, I used all the gadgets of laparoscopy to make it minimal access open surgery. So I give a transverse incision. I took out the whole of the psoas muscle, and I did a gerota and partial nephrectomy. Along with the diaphragmatic resection, we repaired and put a ICD. And the patient is definitely on second day partial nephrectomy as per the partial nephrectomy principles. We clamp the artery, don't clamp the vein, only artery method, and we put the Surgicel and repair. And patient is doing fine on third day, going home on fourth day with R0 resection, all margins negative. And this patient definitely I'm going to radiate. So I put all clips on all sides. So that is how you get a complete R0 resection. And the history starts in 1946, and the person now found was Professor Sugarbaker, who did the first series, 42 cases of multivisceral resection, MVR. And it continues with this German group, Heidelberg, Germany. They have the highest series, 201 cases. And if you see, most of them are sigmoid colon and rectum, but definitely right colon, left colon, depending on the side, the multivisceral resection. Mostly we do right hemicolectomy with duodenal and pancreatic shaving or psoas. partial nephrectomies, diaphragmatic resections. Left side, mostly will end up with distal pancreatectomy and splenectomy. And sigmoid, mostly to the bladder, so you will have to do a partial cystectomy. And rectum, I think Dr. Agentration is a very common procedure, multi-organ, but that is not my topic. So mostly what we see is that these organs that we resect are adjacent, and the surgeon must have expertise to do a pancreaticoduodenectomy at the same time. And on table you decide if the margin is coming onto it, then you go for the resections. All the organs have been mentioned, but recently few of the classifications have come. I will go to them later. And mostly the complications are wound healing because of massive resections. Patients are in debilitated state. You have to take care of the nutrition. There can be anastomotic leaks, pancreatic leaks. So pulmonary complications, mostly when you do a splenectomy, pancreatectomy in the left subdiaphragm, then you definitely end up in some basal atelectasis and pulmonary complications. So all this needs to be evaluated before, and patient to be optimized before being taken up. And survival is best if you achieve R0, and if you have R1 or R2, then definitely you have to take help of your colleagues for adjuvant therapy. Now, the overall survival, if you see 5-year survival, is quite encouraging. It is almost 66 to 70% in all of the series. And this definitely says that multiple visceral resection in all the series. If you see the colorectal, mostly retrospective series, 2,000 plus colorectal surgeries, and you see the number of MBR multivisceral resection around 8 to 10%. And all these resections give you better 5-year survival rate. And so many series have been described, and they have all confirmed that multivisceral resection is definitely a choice, because to start with, if it is localized, and to give a R0 to achieve R0 is not difficult, then you should go for multivisceral resection. Laparoscopic multivisceral resection has also been done by Kim and Feng series, and they have also proved same thing, that the outcomes are almost seen. Indian study, I think Ramakrishna has done a study with multivisceral single institution experience with multivisceral resections. But this Netherlands group, they came up with a classification. And this is an interesting thing I found, that if you have a duodenal anterior wall only involved, then you can resect and do a ileal pedicled flap, and you can just put like a serogel patch, and it's over. Margin is negative. So so many techniques have been tried to achieve the R0. And lastly, I will discuss this classification of MBR, multivisceral resection. They've classified into GI, gastrointestinal, urological, abdominal wall, omentum and ovary, and visceral, that is spleen, liver or kidney. So depending on that, your outcome will be different, your complications will be different, your recurrences will be different. So if you are doing multivisceral resection as a series, you must do this subclassification, and according to that, you do the classification, and accordingly your outcome will be different. In our series, I think last 10 years, we've done around 670 colorectal surgeries, all laparoscopic. I convert only when it is MVR. I have not done laparoscopic MVRs except splenic flexor, 1 or 2 cases. And most of them are open surgeries. And we had mortality of 4 patients due to pulmonary complications and pancreatic complications. And our follow-up is 3 years, and 82% has complete compliance, and we have a good outcome. Thank you very much.
Thank you, Dr. Rudra, for that overview. I think some of these patients need to be probably carefully selected also, and probably tumor biology also should probably play a role, because in your series itself, out of 23, there were 4 mortalities. That is roughly 20%.
Yeah. So I think with recent molecular classifications, I think all these patients should have MSI, and we might come up with some idea of starting in these patients neoadjuvant. But being a surgical center at our place, and definitely we have a MDT, but most of if your triple PCT says resectable, we go for it. But I don't know how much I think neoadjuvant will help.
Yeah, Dr. Madhu?
The 2 questions that we had in mind when thinking about this particular topic was, where would you draw the line, especially in terms of a colorectal or a sigmoid with accentrations? I'm not about rectal cancer, I'm talking colonic cancers. And that's one question. The second is, have we tried out neoadjuvant in this setting, and how many people have actually responded? At least in our hands, the neoadjuvant has not worked out the way we wanted it to work out, or they have remained to be infiltrative into the duodenum or the pancreatic head or the bladder the way it had been prior to start of chemo. So the 2 questions that we wanted to answer by this August gathering was, what should be the limit we should draw, looking at the concept of biology that you brought in? That's one. Second, does neoadjuvant help at all in this kind of cases in downstaging and reduce the extent of your radicality for surgery?
So if you ask me personally, I have done neoadjuvant in few of the cases, but I have not achieved great results. So ultimately we had to do the same resection even if we gave neoadjuvant. So if I remember, right hemicolectomy, going to head of pancreas or to enter wall of the duodenum is a very common presentation. And that's sometimes missed by the radiologist, and on table when you are taking of laparoscopic, once you are lifting, you find that the interval of the duodenum. So these all should be better evaluated radiologically pre-op and accordingly planned, and if necessary, why not resect? I think neoadjuvant has not helped till my knowledge. I think others can have an opinion.
Can I put it another way? We have 2 renowned medical oncologists. Will you give chemotherapy for these cases? I'm sorry, I'm just, I know Senthil will get up immediately.
Only if you said.
Is there an indication?
So I think there is a talk on neoadjuvant chemotherapy, so I'm sure it will be addressed then. But there are 4 successive studies, 2 of which are negative. The Foxtrot was positive for disease-free survival. The data is that it doesn't bring down the incidence of doing multi-vessel resections, but the margin negative resection increases. And margin positive resection, in my mind, is as good as not resecting at all. So that's where neoadjuvant chemotherapy is likely to help. You should also remember that colon cancer is not an area where you get dramatic responses like breast cancer. So there are limitations in terms of the effectiveness of drugs and the situations in which you use. So it helps with margin negative, not necessarily with bringing down the number of organs that you're going to resect.
Maybe we do more biological studies on MVR patients and come out with...
So I feel neoadjuvant chemotherapy could be tried for 2 reasons. One,
gives a test of time. You don't want
Yes.
to do a very major multivisceral resection
Correct.
and then find out that, patient has thrown metastasis in 3 months. Second, it gives more confidence.
Subclinical
More
metastasis.
confidence to the surgeon, not in terms of reducing the radicality of resection, but sometimes even a slight shrinkage of the tumor size would make you think that, yes, this is operable, where you would have initially thought that probably this is not operable.
Just one last question. Yeah.
See, what we have done, I'm not able to give out the data, So generally when we see these cases, immediately the thing of metastasis runs in our mind. The tumor biology is bad, so we go for some PET CT. Don't jump on me that. So we go for PET CT. And after some 3 or 4 cycles of chemotherapy, we go back and repeat the scans, again to see the biology and what is happening. So what we have seen is, many a time the activity of the tumor also goes down. That gives some sort of secure
Confidence.
confidence. And some therapy is available for these guys in the post-op setting also, which is going to definitely help these fellows. It's all in the process of evolution, at least from our center. That's what we are trying to do.
Another point is that not all adjacent organ involvement is infiltrative. Almost 40% is inflammatory. So you have to assess intraoperatively whether you are dealing with inflammation or there is infiltration.
Just one provocative statement. Just my observation. The tumor biology, I think, is good because in spite of having infiltrated adjacent organs, it has not thrown up metastasis. That's one. And let me share one of my personal experiences. I find that a large proportion of these patients are N0.
And
Large
correct.
number of our T4s are turning out to be N0. So I believe that the biology is better because of the fact that they're remaining N0 and not thrown up metastasis in spite of having T4A, B, C, etc. A smaller tumor have metastasis. So these are 2 observations I have seen in my clinical practice.
Just, I think Dr. Ramakrishnan mentioned about the margin negatives improved by chemo. So any experience of chemo radiation in these patients, neoadjuvant?
I don't have any experience. But definitely it will depend on the site of tumor. Maybe posterior wall of cecum going to, like this patient had 2 years back radiation, post surgery, chemo and radiation both. But after 2 years is coming with a mass in the psoas going to the kidney. So it is definitely the biology is bad. We cannot do. But one thing is that I have one patient where I have done MBR and he's still surviving and he's almost 8 years. So you may not know that they don't metastasize, but they do locally recur.
So just a point regarding neoadjuvant also, is there any like experience on neoadjuvant immuno? Because we had so we had like two recent patients where it was like transverse colon malignancy, which is inoperable, is involving the SMA and SMV, but post 2 cycles of nivolumab, patient developed obstruction.
Yes.
So we had to operate, then turned out to be PCR. Yes.
Okay. I think thank you, sir, Dr.
Thank you very
for
much.
the
Thank you.
excellent talk.